Okay, we have other speakers that have to speak now, and I'll be up here a few times asking questions and leading us through a discussion. But before we go any further, we must learn about the endocannabinoid system. Stefan, please come up and give your presentation.
So I'd like to first thank you all for being here today. It's an honor to be here, to be among the first people in Sweden to actually teach about the endocannabinoid system and its importance in health and disease. I am a receptor pharmacologist by trade, but I'm also a pain patient. So I'm hoping I will be able to give you some perspectives from both sides. With that, I'm going to start by reiterating some of what Angelica said in the beginning, actually. It's a little bit of a reality check where we are in Sweden today. I think, let's see, nothing is happening. Sorry about the technology issues. Here we go. Oh, they're all coming at the same time. So doctors in Sweden are generally not aware that there are existing cannabis-based medications available that they can legally prescribe to eligible patients. And doctors in Sweden generally have no idea how these medicines works. And that is the main reasons that they are hesitant to use them in practice. Doctors in Sweden are not seldom fearful of potential work-related repercussions from non-agreeable bosses should they start to prescribe cannabis-based medicines to their patients. This is a fact. And doctors in Sweden generally believe that the use of cannabis-based medicines is inferior in efficacy compared to modern-day synthetic medicines. Also, doctors in Sweden, and maybe the general public by large, also perceive cannabis much more towards that of a harmful drug of abuse than that of a well-tolerated and efficacious ancient multi-purpose medical plant. Obviously, it can be a drug of abuse, but it definitely can be a multi-purpose medical plant. And that I want to challenge here to do today. This needs to change, and this is one of the reasons why I chose to stand up here today to talk to you. So my background, I'm a PhD in molecular pharmacology. My interest became already as a master's thesis student, I became interested in G-protein coupled receptors. And this is a superfamily of receptors with over 800 different genes in the human genome. About half of them are olfactory and gustatory chemosensory sensors, so they are involved in our ability to sense smells and tastes. About 360 of them are endo-GPCRs, which means that they respond to signals from within the body. And of the 360 receptors, 100 of them are still classified as orphan receptors, meaning that we do not know what binds to these receptors. But receptors do not occur by chance. They always have a purpose. We do not have any receptor in a body without their specific purpose. So CB1 stands out from the crowd of these GPCRs in multiple ways, which makes it uniquely attractive and exciting. I think I dare say to any receptor pharmacologist. And it's got to do with CB1 has actually one of the highest expression levels of all G-protein coupled receptors in the brain. So what we're looking at here in the picture is a radio-labeled PET ligand that binds to cannabinoid receptors in human brains. And as you can see on the leftmost part, it lights up almost everywhere, it looks like. So we have a huge abundance of these CB1 receptors in the brain. And we don't have receptors for just them being there. They have a purpose. And if there are so many of them, they must have a big purpose. The other thing about the CB1 receptors is that its discovery sparked the whole hypothesis of the endocannabinoid system. And the man you can see on the right here is Dr. Meshulam, Dr. Raphael Meshulam from Hebrew University, also known as the godfather of cannabis. He was the first to isolate and synthesize THC and CBD in the mid-1960s. And then following 3 decades of hard work, he again returned to the limelight of cannabinoid research and made 2 more super important discoveries, namely the first discoveries of endocannabinoids, anandamide in 1994 and 2-AG in 1995. And just to fill in the little blanks in the endocannabinoid system and how early or how for such a short time we've known about it. So in 1990, the CB1 receptor was first cloned. In 1993, the CB2 receptor was first cloned. Same year, we found the fatty acid amide hydrolase, which is the enzyme that is responsible for degrading anandamide, one of the endogenous endocannabinoids. And then in 2002, the enzyme responsible for degrading 2-AG, MAGL, was discovered. So a point I want to make with this is that the whole discovery of the endocannabinoid system is very, very new. So doctors age 55 over, they probably never even heard about it. They definitely have not been taught about it in medical school. CB1 receptor is interesting to me because it has completely unique pharmacodynamic properties. Pharmacodynamic means what it does to the body. It is directly involved in synaptic health and homeostatic mechanisms, both centrally as well as peripherally. And as I said, this receptor is especially interesting to me because I'm also a pain patient. I suffer from something called post-traumatic trigeminal neuropathy. I got half of my left ear bitten off in a work-related accident 4.5 years ago. This was not during a time I was working in a lab. We're usually not that aggressive. But if you're interested in the details, I'll be happy to talk it over at the water cooler or in the bar later. But it was quite traumatic. But what happened was that the mandibular nerve in this case, which is part of the trigeminal nerve bundle, which innervates a significant portion of the left half side of the face and jaw, was damaged. And I have since gone through several reconstructive surgeries to correct the aesthetics as much as possible. But unfortunately, I do suffer from neuropathy. I have an omnipresent tingling and burning sensation in my left side of the face, originating from the ear. I classify the pain as unmedicated, about 5 to 10, 5 out of 10 on the visual analog scale. I also have allodynia, meaning hypersensitivity at the outermost part of my earlobe. So it's hypersensitive to touch, temperature, wind. And I do get these recurring, spontaneous, electric shock-like debilitating pains, which are more, they hurt a lot more, but they're not constant. They come and go. And they're very dependent on stress levels, mood, a lot of different factors I found playing. So there will be a couple of images. If you're sensitive to tissue damage and blood, look away for a few seconds, but I just want to show you what actually happened to me. So on the 18th October of 2017, this was 2 days after the accident, they had reattached the lower part of the ear, but unfortunately, due to necrosis, they had to remove it again, which is what you see on the right image. A week after or so, they did some graft emplacement on the wound, and 1.5 years later, I had a reconstructive surgery using a rib graft from my own rib. So basically, this is what it looked like after a little less than a week, and this is what it looks like today. So it's quite impressive, the plastic surgeons. I'm very happy that we have such talented plastic surgeons in Sweden. But unfortunately, I do have these pains that seems to be chronic, that I have to deal with. Being a molecular pharmacologist and interested in cannabinoid science, I started looking into whether there is any indications that cannabinoids can be helpful in my case. And you can all read the title. It's pretty clear that there is a therapeutic potential of cannabinoids in trigeminal neuralgia. Other papers came out that says that cannabinoids have a therapeutic avenue, and they also describe the downstream targets of these cannabinoids, how they actually work to benefit. Another paper came out that says you get sustained relief of trigeminal neuropathic pain by using a blood-brain barrier penetrable PPAR gamma agonist. And what is that, you might wonder? Well, it turns out that actually CBD, THC, and anandamide and 2-AG, all of those are blood-brain barrier penetrable PPAR gamma agonists. They can't patent it, so you can't make the money. So Big Pharma is not as interested in it, but this makes a lot of sense why such compounds are good to treat neuropathic pain. And then in 2019, there was a small study being made that I managed to find. Turns out that 81% were responders and have symptomatic relief when they could use ad libitum cannabis to treat their symptoms. And half of the patients were able to decrease their opiate use. Then there was a turn of events in my life. My general practitioner, out of nowhere, stopped prescribing me the only medication that I had been using up to this point, pregabalin or Lyrica. It's a medication usually used for epilepsy. And not everyone has a PhD in receptor pharmacology and a thirst for knowledge and an interest in cannabinoid science, and neither should you have, but I do. So I decided to discuss this with my GP, since he didn't want to continue the only medication that had been working for me. And you can all guess the response that I got from him. It was not good. And this was the tipping point for me, and I decided that the public health care is not up to par with science, or nor are they fully interested in promoting my health and well-being when it comes to this disease. So I went to a private neurologist, got to try Sativex for 3 months. Turns out it worked very well for me. Got a license from Läkemedelsverket to use a licensed product called THC CBD12, which is a full-spectrum oil from Emerald or Stenocare. And it was approved for a time. And now I'm using dronabinol and cannabidiol with not quite as good, but almost as good effect as from the full-spectrum oil. So how have these medications affected me and my pains? Well, using the Lyrica at maximum daily dose, it decreased my pains from 5 to 4, not a big impact, and maybe it decreased the shock-like debilitating pain by 1 margin. Didn't do anything to the frequency or the duration. Now, when I'm using about 50 milligrams of THC and 100 milligrams of CBD, I have a significant reduction in the omnipresent neuropathic pain, the burning sensations in my ear and the tingling. Most days, for some days, I forget about it. I don't feel it anymore. The allodynia has been lessened. Being outside in really cold weather has always been very discomfortable, but I have been able to not use a cap this winter for a few times. Also, the spontaneous electric shock are less painful and they are less frequent, and the duration also seems to be a little bit lessened. That was a little tangent on my side story. Now I want to get back into what we want to talk about, the endocannabinoid system. What is it? Well, it is our bodily cannabinoid system, and endo stands for from within. And its existence actually gives us the scientific explanation into how and why cannabis-based drugs function on a molecular level, and how they can have such multifaceted medical properties. And its discovery has actually revolutionized our understanding into how our bodies, against all odds, work to maintain the internal homeostasis against an ever-changing environment. Endocannabinoids are what we call cannabimimetic, which means that they share both mechanisms of actions as well as the physiological effects of the more well-known psychoactive phytocannabinoids, THC and CBD. So the main components in the endocannabinoid system is the CB1 receptors, obviously. They're primarily expressed within the nervous system, both centrally and peripherally. But we do have expression in peripheral organs, especially in metabolically active tissues, such as adipose tissue, liver, and muscles. If we pull up some data from a website called the Human Protein Atlas, everyone can use it. So you can just put in which gene you're interested in, and then you can get some data in what kind of tissues and cells this gene is expressed in. And we can see to the left here, different brain regions. We have high expression levels in the cerebral cortex, which got to do with our rational thinking. We got high expression levels in cerebellum and basal ganglia, which got to do with voluntary movement. Hippocampus, very important for memory formation. The amygdala, known as our fear center, is part of our limbic system, our reptile brain. It's a very ancient part of our brain, high expression of CB1 receptors. Also to notice that we have a high expression in the pituitary gland, which is located just downside of the hypothalamus and is really the link between our nervous system and our endocrine system. We also have high expression levels within adipose tissue, and what you can see here in breast is mostly adipose tissue. You can also look at what types of cells that do express the CB1 receptor, and what stands out is it's neurons. It's inhibitory neurons and it's excitatory neurons. And we'd also have high expression in Sertoli cells, which is a precursor to sperm cells.
Excuse me.
Sure.
Where do you put, if we, do we have any botemedel? Cure, sorry, thank you. For
Bipolarity.
bipolarity. Are there any?
I'm sorry, I wasn't really ready for that. Hello?
Testing, yeah.
Okay, I just want to ask you if you have some cure for bipolarity.
I wouldn't want to say that we have a cure for bipolarity.
A strain.
A cannabis strain, you mean?
Yes.
I don't think so that there is one specifically developed or efficacious for that. But I will not talk so much about phytocannabinoids. I will talk more about the endocannabinoids. Okay, let's move on to the CB2 receptors. They have high expression levels within the organs, tissues, and cells that are involved in the immune system. We see very high expression in the spleen, lymph nodes, tonsils. And there's also, maybe not high expression levels, but they have a very huge importance in the GI tract. And that's why I have marked it in this color here. And obviously there's an overlap. There's also CB2 receptors in the immune cells in the brain, for instance. So they're not exclusive. We also can look at which cell types do we find the CB2 receptor in. And as I said, it is in the immune cells with the highest expression level by far in B cells, which are the cells that produce our antibodies. So, another component of the endocannabinoid system, at least it hasn't been classified originally as a component, but more and more researchers nowadays want to say that this is actually a component of the endocannabinoid system. And I agree, because the endocannabinoids, anandamide and 2-AG, both interact with these receptors, at least some of them. They are TRPX receptors, or transient receptor potential receptors. The TRPX1 is the most well-known receptor. It's actually called the capsaicin receptor, and it is what is activated by chili peppers on the tongue. It's also activated by CBD, the endocannabinoids. It's primarily expressed in nociceptive neurons, but can be found in cells throughout the entire body. So here we have anandamide and 2-AG. Again, only discovered in 94 and 95. This is what they look like. So endocannabinoids, they have the unique function as the regulators of synaptic nerve transmission, and they act as retrograde modulators of presynaptic neurotransmitter release. And that's a lot of complicated words, and I will show it in a couple of slides later on. Our endocannabinoid system is activated only if it is necessary, when it is necessary, and where it is necessary. And activation happens on demand through acute endocannabinoid synthesis, activating CB1 and CB2 receptors. And these are actually not the only endocannabinoids that we know of. Recent research have shown that there should be at least 3 more compounds that should be classified as endocannabinoids. We call them NADA, virodamine, and 2-AG. But there's so little known about these guys, so I'm not going to even talk about it. It will make it way too complicated. But you can see at the structural level, they all look very, very similar. It's a arachidonic acid coupled to an amide, essentially. So we have our receptors, and we have our endocannabinoids. Anandamide works as a partial agonist, and 2-AG works as a full agonist as the CB1 and CB2 receptors. This means that anandamide activates them to a degree, maybe 40-50%, whereas 2-AG activates them to their maximum extent. 2-AG is present in the human brain in about 100 times more higher concentrations than anandamide. Both of these compounds interact with a TRPV1 receptor. How does THC and CBD and cannabis fit into this? Well, THC acts very, very similar to anandamide on the CB1 and CB2 receptor. It's a partial agonist. It activates them to a degree. CBD, on the other hand, has the other part. It activates TRPV1 receptors, but it doesn't have a direct effect on the cannabinoid 1 or 2 receptor. But it has a very important secondary, or maybe I should say primary effect, because eating CBD actually increases your levels of anandamide by blocking the enzyme that transports it to the degrading enzyme inside the cell. There's a terpene found in the cannabis called beta-caryophyllene. This is actually also a cannabinoid. Can you imagine? It interacts. Sure.
THC
Yes.
also affects this anandamide?
No. Only CBD. Sure. So beta-caryophyllene is actually a CB2 specific agonist, which is something that Big Pharma is looking to develop, because a CB2 specific agonist won't have any effects on the central nervous system located CB1, so it will be void of any psychoactive effects. You won't get high from it, but you will get a lot of benefits, probably preferentially in inflammatory diseases and diseases where we know that the CB2 receptor is of high importance. We also know that one of the most prevalent terpenes, myrcene, is also a TRPV1 activator. So it's silly to try to reduce the complexity of the cannabis plant into 1 or 2 single compounds. It is a multifaceted, multi-drug. You have to be aware of that. Moving on, homeostatic mechanisms dictate our physiology. I'm just going to go through this a bit quickly, but we have 11 different systems in our body, and in all of them, we need to keep homeostasis. Means, for instance, in the endocrine systems, we need to keep our hormonal balance. We can't have too much hormones, we can't have too little hormones. It needs to stay in a set defined area, or it will cause disease. Another good example is in the immune system, where we always constantly need to balance self-tolerance towards self-intolerance and the detection of foreign invaders. We have in the muscular system where you have to have homeostasis in the metabolic rate. The nervous system, homeostasis issues there can cause difficulties in emotion and pain and cognition. We have the pulmonary system, which needs to strictly regulate oxygen and carbon dioxide levels. And the skeletal system needs to regulate bone density, or we will suffer from osteoporosis. Well, actually, all these 11 systems stands under the control under the endocannabinoid system. So we don't have 11 physiological systems. We have 11 plus one master regulatory system, the endocannabinoid system. So a way to look at whether something is important or not is to see whether something is conserved throughout evolution. So what I'm doing here is I'm looking at the cannabinoid 1 receptor, and I'm looking at whether it differs from the orthologs, the gene, the cannabinoid 1 gene found in the different species. So the human actually has 100% identical cannabinoid 1 receptor to the macaque, 97% identical to the rat and the mouse, 91% identical cannabinoid receptors to a finch, and a salamander 82%, a pufferfish 72%. And there's actually a few invertebrates that now have been discovered to also have CNR1 gene. The eagle there, no, not eagle, that's Swedish, leech, has also found to have CNR gene with 58% identity to the human gene. And a DNA sequence or a gene which changes very slightly throughout evolution, that indicates that it's an important gene with important functions because it has been conserved throughout natural selection. So a little recap. CB1 is among the most prevalent receptors in the entire central nervous system. Receptors only exist to fulfill biological functions. CB1 is hence likely to be one of the most important receptors in the nervous system. CB1 signaling works in the opposite way to regular neurotransmission. It's retrograde signaling, mediated through negative feedback loops, which maintains homeostasis, which is a necessity for life. We'll go in a little bit in detail on how this works in the central nervous system. To the right, we can see a pyramidal neuron, which gets signals from several inputs. And whether this neuron will decide to fire and pass the signal on downwards will have to do with the balance of the different neurochemicals. So we have excitatory synapses, which use acetylcholine, glutamate, or noradrenaline. And then we have inhibitory synapses, which utilize GABA, glycine, or serotonin. So the excitatory, they increase the propensity of another action potential being generated. So it stimulates the area of the brain, makes it more excitable, whereas the inhibitory signaling does the opposite. It lessens the chance of additional firing in that part of the brain. So in this case, we have an excess or an overweight of glutamate or noradrenaline compared to GABA, which means that this cell decides to fire. And we zoom in much more closely now. We're looking at the synapse, a synaptic cleft. We have a pre-synaptic neuron and a post-synaptic neuron. The firing, the nerve signal comes here and goes downwards. So what happens is we get a neurotransmitter release. Say it's an excitatory neuron, so in this case it's glutamate. Glutamate binds the glutamatergic receptors, and that brings up the local calcium concentration in the postsynaptic neuron. This, in turn, stimulates the production of 2-AG from a phospholipid. And phospholipids are what constitutes our cell membrane. So these are found in every cell in the body. All cells have the capabilities to produce endocannabinoids. So the 2-AG is transported through a purported transporter protein, which has not been located yet. But in the synaptic cleft, it binds to the CB1 receptor, which inhibits calcium from entering in the presynaptic cleft and thus inhibiting further synaptic release. So this is a negative feedback mechanism. The 2-AG can also work on the TRPV1 receptor, as I said earlier, which would have diametrically opposite effect as its effect on the calcium channel. It would increase calcium influx. But different cells express TRPV1 compared to this, and this is just an illustration to get all of the different targets into one synapse. We also have the generation of anandamide. It occurs also from a phospholipid called NAPE and an enzyme called NAPE phospholipase D. The anandamide gets transported into the synaptic cleft, where it's free to bind to its different targets, being the CB1 receptor, which again inhibits calcium influx into the cell, which inhibits further neurochemical release. It also interacts with the TRPV1 receptor, both on the presynaptic as well as on the postsynaptic terminal. Included in this picture now are also the enzymes responsible for the degradation. So now we actually have all the components of the endocannabinoid system in the picture in the synapse. We have the CB1 receptors, we have our endocannabinoids, and we have the enzymes that produce, and the enzymes that degrade the endocannabinoids. So, where does CBD and THC fit in here? Well, CBD actually inhibits the transportation, as I said, of anandamide into the degrading hydrolase, which is located here in the endoplasmatic reticulum. And that will increase anandamide levels. It also binds to the CB1 receptor at another, not the orthosteric site, but an allosteric site. And that means that it works as a negative allosteric modulator. When CBD binds to the CB1 receptor, any additional binding in the orthosteric ligand binding site will require higher concentrations. So if you have CBD in combination with THC, it attenuates the effects of THC through this mechanism. Okay. Thought we're gonna go through more about the homeostatic mechanisms that are so essential to the endocannabinoid system. I hope you're all with me so far.
Yes, we are.
Thank you, Andrew. So neuroendocrinology, what's that? Well, hypothalamus is a part of our brain, and it's a part where we integrate different signals from different parts of the brain. So we have inputs from the cortex, we have inputs from sensory neurons out in the body. It's a collective integrating center. And together with the pituitary, it makes up the link between the nervous system and our endocrine system. And there are huge amounts of sensory neurons found in control centers that can detect if any one of our hormonal systems are starting to deviate from homeostasis. So inside the hypothalamus, which produces hormones directly, such as vasopressin and oxytocin, they also produce these release and release inhibiting neurohormones that act on the pituitary, which in turn release gonadotropic hormones or prolactin or adrenocorticotropic hormone acting on cortisol levels. It's a whole balance with hypothalamus being on the top of the pyramid acting on all the hormonal regulations. So how does the CB1 and receptor and the endocannabinoid system fit into this? Well, we do get, when we're stressed, we get an increase in the corticotropin-releasing hormone from the hippocampus, which acts on the pituitary, which releases adrenocorticotropic hormone, ACTH. And that in turn acts on the adrenal cortex, giving us a rise in cortisol levels. And the cortisol levels actually inhibits through 2AG. It has feedback mechanism through 2AG. Another way to look at this is in a no-stressing situation, we have higher anandamide levels and a blocked stress response. We get an acute stress, or an acute stressor happens. We get an upregulation of this fatty acid amide hydrolase enzyme, which degrades anandamide, which means that we get lower amounts of anandamide, lower amount of CB1 signaling, and an active stress response. Then the homeostatic mechanism is this active stress response actually increases our cortisol levels, which then increase our 2AG levels, increases our CB1 activity and diminishes this stress response. We also have an adaptive protective mechanism. If we're subjected to the same stressor multiple times, our response will generally attenuate by time, and this is because it also increases 2-AG levels further on, so we get an attenuated stress response. When we have chronic stress, is another story, because then we have an epigenetic downregulation of the CB1 receptor, which means that the anandamide and the 2-AG, they don't have any CB1 receptors to act on. So it becomes a negative feedback loop in a bad manner in this way. So the feedback loop from the cannabinoid receptor on the hypothalamic pituitary adrenal axis, which causes the stress, is blocked, and we have increased cortisol levels. I want to talk to you also a bit about PTSD and the brain and endocannabinoid system. Not because there's extremely much clinical evidence, because there hasn't been many clinical studies made, but the scientific rationale is very, very clear, I think, in this case. So the amygdala, it's a small almond-size part of your brain, just below your hypothalamus. It deals with constant situational awareness. And people with PTSD, they have a hyperactive amygdala. So they're constant situational awareness, they're always on guard, never able to fully relax, suffer from intrusive dreams, flashback-like symptoms. And it's because the amygdala tries to answer in real time whether our surroundings are safe. What is the change that's happening? Is it good? Is it bad? Is it safe? Is it scary? And the amygdala response is usually overridden by rational thinking using our cerebral cortex. But in patients with PTSD, our rational thinking is significantly impacted. And their amygdalas are hypervigilant. And this is actually a very nice paper that shows this in detail. So what they're looking at is functional magnetic resonance imaging in PTSD patients compared to control patients. And the yellow is more active than controls, the blue is less active than controls. So PTSD patients, they really do have a hyperactive amygdala and a hypoactive prefrontal medial cortex, which got to do with our rational thinking, which stops us from thinking that this acute stressor, it's not this response that I'm having, it's over-exaggerated, but that feeling is lost.
About lost picture, do you have some strains that work with this kind of problem?
No, sorry. Absolutely. So this is another PET study, and it's very interesting because this does not look at functional magnetic resonance imaging or the activity. They have a radio ligand. It's actually an inverse agonist that binds to this central CB1 receptor very, very strongly. And because it's radioactive, we can see it in this scanner and can see where it accumulates. And it seems like people with PTSD, they actually have 20% higher or 20% more binding sites within their brains, 20% more CB1 receptors that are available to bind, if so to say. And how can this be? Well, at the same time, the PTSD patients have significantly decreased anandamide levels compared to both healthy controls and trauma controls. Trauma controls are patients that have been suffered trauma, but without being diagnosed with PTSD. This means that probably what we see on the left is a compensatory mechanisms. Because of such low anandamide levels, the brain tries to upregulate the CB1 receptor. This is also very interesting. They looked at circulating endocannabinoid levels in individuals with post-traumatic stress following the exposure of the World Trade Center attacks. And in this case, they didn't see any effect on the anandamide, but they saw a significant reduction in 2-AG content. So, serious stressful events have serious impacts on our endocannabinoid system. This is also very interesting, I think. This is functional MRI study using 16 healthy recreational cannabis users, which have either been pre-dosed with placebo or THC. And then they are shown threatening or non-threatening images to see whether the amygdala lights up. And in the people that have been pre-dosed with THC, there is no hyperactivity in the amygdala, or there is no amygdala response compared to placebo. Another paper, when it deals with fear extinction, learning and recall, which is also very much in line with PTSD, an over-exaggerated response to a stimuli. If you want to de-learn that, it seems like THC actually increases the activity of the prefrontal medial cortex, as I said earlier. So trying to put this together is that in PTSD we have a hyperactive amygdala and a hypoactive ventromedial prefrontal cortex. With the THC, we can reverse these effects and actually balance out. And that's why I think PTSD has a very, very nice future ahead of it with pharmacotherapy for cannabis. I can see that my time is almost running up, so just quickly go through the last slides. There's a big hypothesis around that supports a clinical endocannabinoid deficiency because there's a huge comorbidity between different symptoms. And for instance, in migraine, it's a very, very small study, but 20 patients in this, they had 0.4 picomole per milliliter. 15 patients with chronic migraine, they had half the amount. And as I said, there's this comorbidity with patients who have migraine, fibromyalgia, and IBS. I think it's about 30% of people diagnosed with fibromyalgia also fulfill the clinical symptoms for IBS. Animals who lack the genes coding for CB1 and or CB2 have the following phenotypes. This is just to give you an example of how important the endocannabinoid system is. And we can't really knock out the receptors in humans, so we have to trust the animal experiments. So cannabinoid receptor 1 and 2 double knockout mice, they develop epilepsy. CB1 receptor knockout in mice leads to leanness, resistance to diet, induced obesity, enhanced leptin sensitivity. Cannabinoid 1 receptor knockout mice displayed cold allodynia, but enhanced recovery, which means they definitely got to do with neuropathic pain. CB2 receptor knockouts have impaired contextual long-term memory, but impaired spatial working memory. So again, very, very important physiological functions. And communication and social interactions seems to be dysfunctional in cannabinoid type receptor null mice, which has implications for autism. I'm going to skip this one. This is very interesting. Rimonabant, I think it was the first developed CB1 blocker because, as everyone here knows, or many of you, I suppose, eating or smoking cannabis gives you the munchies, you get hungry. So they thought, why not block this receptor? That would be a great anti-obesity drug. But what could possibly go wrong, you think, by inhibiting the master regulatory system? Because as we know, CB1 receptors don't only deal with appetite. So findings from the meta-analysis that followed was that the participants in the trial had a significantly increased risk of psychiatric adverse events. And despite that, depressed mood was actually an exclusion criterion from even entering in the clinical trials. And furthermore, there were 2 patients in this trial that were found to have committed suicide. It was only released in the European market in 2006, and I don't think it lasted for more than 6 months or so. It was never released in the US. I'm going to end you with this, because I think it's interesting. Not many of you know that the analgesic effect of paracetamol, or as it's known in the US, acetaminophen, is actually mediated by the endocannabinoid system. So to the left, we have a CB1 knockout mouse, and we give it paracetamol, or rather we injure it, we give it paracetamol, it will have pain, no analgesia. We can also do the same thing. We have an ordinary mouse, we give it a CB1 antagonist, which mimics having no receptors. We injure it, it will feel pain. But if we inject a brain-permeable FAAH inhibitor, remember this is the enzyme that degrades anandamide. So it's brain-permeable, we inject it in the tail, so it goes into the brain, we injure it, but it gets anesthesia. If you do the same thing with a brain-impermeable FAAH inhibitor, they don't get any anesthesia. So it's centrally located FAAH that deals with the mechanism of action for analgesia. And this can be described in this. So paracetamol is actually a prodrug, which gets deacetylated in the liver into para-aminophenol, which by FAAH enzyme combined with arachidonic acid creates this AM404 active metabolite. And this inhibits the free FAAH enzyme again, increasing anandamide levels, giving you increased endocannabinoid tone through CB1 receptors and TRPV1 receptors, and pain relief. And just to give you another hint, I mean, it's not surprising if you take a look at this molecule, which is one of the newer found endocannabinoids, NADA. It's almost identical to this metabolite. It has one more hydroxygen here, but otherwise they're identical. So paracetamol actually works as a prodrug for the endocannabinoid system when it comes to mediating analgesia. And with that, I want to thank you for listening.